Disclosures for this and all episodes in this series can be found on the podcast series destination page located on education.webmd.com. The following presentation is copyrighted by WebMD Education. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of WebMD Education. The following podcast is supported by an independent educational grant from Bayer.
So welcome back to our podcast on preventive cardiology and preventing cardiovascular risk. My name is Dr. Michael Blaha. I'm at the Johns Hopkins Ciccarone Center for the Prevention of Cardiovascular Disease. And we are on to episode 5 in this series with the theme of Know Your Risk and Act Early. So we've covered primordial prevention, we've covered calcium scoring, carotid ultrasound, and some basic pharmacologic decision making about preventing cardiovascular risk. But now it's time to make it real and really illustrate how imaging tests can change decisions at the bedside or in the clinical arena. I'm absolutely thrilled to have with me my friend and colleague, Dr. Fatima Rodriguez, who is the Vice Chair of Clinical Research at the Department of Medicine at Stanford and Section Chief of Preventive Cardiology at Stanford School of Medicine. So, Dr. Rodriguez, thanks for joining us again for this podcast.
Thank you so much, Dr. Blaha, on a very real topic.
Yes, it is. So we're going to make it real here because, of course, we can talk about risk all day. We can talk about the value of imaging tests in theory, but it only matters if it can actually be applied to real patients. And I think I can speak for myself, and I know for Dr. Rodriguez, that we routinely use imaging tests and risk scores in our practice to get a holistic view of the risk of the patient and make decisions that are directly impacted by the results. So we're going to start with some rapid fire cases. Everyone will find these familiar, right? Every day, whether it be in your clinic or even on the sidelines of your kid's soccer game, people are asking simple questions like, well, should I be taking a statin? Should I be taking an aspirin? What's my blood pressure supposed to be? And it's hard to answer that question until we know the risk of the patient. So let's go into a case. A typical patient, let's say a 55-year-old, this case a man who's in your clinic, and he has borderline risk values. His LDL is 130. His blood pressure is 130 over 80. His triglycerides are a little bit elevated, maybe 160, and his HDL is about 40. He's clearly got borderline values. And let's say this is someone who came on his own. He found your clinic, he found you online and says, I just think I should talk about whether I should be on therapies because I'm getting at that age. I feel like I'm at risk for heart disease. Let's start with the initial risk evaluation of this patient. So I mentioned 55-year-old man, borderline LDL, borderline blood pressure, his triglycerides just a touch high. Maybe he's a couple pounds overweight, but otherwise not too bad. So how would you start with a patient like this?
First of all, if a patient seeks preventive cardiology in our clinic, it's either for two reasons. They're prevention seeking, so they may want to start therapy, or they're trying to avoid a therapy that another physician recommended. So I think for this type of patient, if you plug in his risk factors in our prevent equation, which again is our new risk equation recommended by the 2026 cholesterol guidelines, he may be in the intermediate kind of gray zone for starting therapy and really around shared decision making. So there are two options. If the patient says, hey, doc, I just want to lower my risk as much as possible, you can just proceed, start a statin, and monitor the risk factors. However, many of our patients are like, I would like to get more information. I just feel like my information is incomplete. I'm a middle aged man. I just heard somebody at work had a heart attack. How do I prevent that risk? So then a calcium score becomes extremely helpful. And a patient like this, a calcium score would really change management, would change lipid targets. So I would offer a calcium score to this patient to get more data. And I'll say that 9 out of 10 times, the patients want more information and they do want a calcium score.
Yeah, that's a great point. So at my institution, at least, the calcium score is only $75. I know it varies by the institution, but let's say this guy was agreeable. He said, that sounds like a great idea. That's really what I came here for. I wanted to know my risk. And I actually went online and did the prevent equations myself, and I was intermediate risk, and I didn't find that very helpful. So yeah, let's do that calcium score. I read about that. Let's say he gets the calcium score done, and the score comes back as 350. So how do you start the conversation with the patient at this point?
So score of 350, like we reviewed, I believe in our second episode, is high, right? And this is really a risk very similar to those who have established chronic coronary disease. So again, if we just used his risk equation alone, we would say he's borderline intermediate risk and we may not treat any of his risk factors. So this really confirms atherosclerosis is present. I would even say he has coronary artery disease, even though it's not obstructive and he's asymptomatic. So this really shifts the conversation from should we treat to let's see what we can do and hopefully reduce your risk with a combination of medications and lifestyle. And from the patient's perspective, there's always more buy-in. The patient has almost always already looked at the number and they have ideas around it. I say it's okay. We're going to target this. And I show them the picture. So I always start with the picture. These are your arteries and these are plaque in your arteries. And now we're going to do things to reduce your risk of heart disease. And let's talk about what those are.
Wonderful. That's so good. Yeah, and I'm sure you've got his attention at this point. So let's run through some of the decisions. How about aspirin? This is always a controversy. Does he deserve an aspirin for primary prevention?
Coronary artery calcium scores above 300, I really treat exactly how I treat my secondary prevention patients. A lot of the work that you've led on this really have supported the use of aspirin for a calcium score this high. So I would recommend aspirin 81 milligrams for this patient.
Okay, I agree. I would too. How about blood pressure? So mentioned his blood pressure was 130 over 80. So where does that stand and what should we do about it?
Yeah, with the current guidelines, I would recommend lowering that blood pressure. Again, sometimes now that you said he's a few pounds overweight, so sometimes blood pressure is exquisitely sensitive to a little bit of weight loss. So I think that one would not be, in terms of not overwhelming the patient, would maybe be my third thing that I tackle after LDL and starting an aspirin. But yes, very reasonable to lower this patient's blood pressure to a target under 120 over 80 because he has what I consider the equivalent of coronary artery disease.
Yeah, great point. You're right. And it always starts with lifestyle. So if you can do it with lifestyle, great. Sometimes, of course, you can. Which brings us to cholesterol, where I think probably we can't get to our goals without pharmacologic therapy. So I mentioned his LDL started, let's say, at 130. So first, what would his LDL goal be?
For a patient with a coronary artery calcium score over 300, the guidelines was currently say target under 70 milligrams per deciliter. I'll say that in my practice, very similar to coronary artery disease. There's no high risk features here, but I do target under 55 milligrams per deciliter.
Okay, so let's say he says, okay, I'll go on a statin, but I'm worried about statin associated side effects. I'll go on a statin, but I don't want to go on the highest intensity statin. So would that get him to goal, do you think?
I don't think so. And I think that's a really important point. And I've been an attending for 10 years now. And I'll say that my conversations around LDL lowering therapy have really changed over the years. We were taught no matter what, this patient needs to be on a statin, the highest intensity, highest dose statin. I don't have those conversations anymore. I say we have many, many tools to lower LDL cholesterol. We'll find the right one for you. And that immediately calms people because, again, most of the patients who come to our clinics may not be particular fans for statins because of what they've read online. So I think combination therapy, particularly if the patient is resistant to starting higher intensity statins, I think rosuvastatin 5 milligrams and ezetimibe in combination, again, generic medication is very well tolerated, may get him to goal, and then we can increase the statin dose as needed.
So that's a great point. Yeah, combination therapy came out loud and clear in our new guidelines. We're going to intensify when the calcium score is high. We're going to try to get to LDL goals, and that commonly will require combination therapy, like you said, which can still be a combination of generic, cheap medications. Only in select cases will we need to reach for things like a PCSK9 inhibitor, but that's a great value too. Now, I'm coming back to diet and exercise. The reason why I started with those other things first is, of course, we're going to have to go jump right in and talk about medications for this high risk patient, but diet and exercise should always be emphasized too. So, what specific diet and exercise recommendations would you make for this individual beyond what you would recommend just for everyone?
That's a great point. And I think when many patients come see us in cardiology clinic, they think we're only going to push medications. But actually, I will start by saying, what supplements do you take? Many of these patients, even though they don't take any medications, take a lot of wellness supplements. So I usually say you can stop all those. I'm going to save you some money. You can stop all those supplements and let's focus on lifestyle. What things are not negotiable for your heart health and really for your overall health? So I spend a lot of time talking about diet, especially it seems like weight loss is important. Just being aware, monitoring what you're eating. It sounds like he has early metabolic syndrome with the lower HDL, elevated triglycerides. I say, especially triglycerides, exquisitely sensitive to diet, a diet low in saturated fat, simple carbs. I tend to recommend a Mediterranean like diet, plant forward, but no specific diet, just something that an individual can sustain long term. For exercise, again, many of our patients will show up and say, I heard that cardio is what really matters for heart health. And now we have some evidence to suggest that it's really about consistency, exercising routinely, and also strength training is particularly valuable for patients with this insulin resistant profile.
Yeah, that's a super important point. So let's get back to the imaging piece. So we made a lot of recommendations here, but what if this patient's calcium score was zero? Would that conversation be different?
So a calcium score is zero in this patient, already you said he's 55 years old, really de-risks them. And again, it may be surprising for many of us if his score came back at zero, but it helps us just step back and say, okay, we have a little bit of time. The sense of urgency has gone, and we can really get more buy-in around, maybe start with the lifestyle and then focus on all the other risk factors.
I agree. So yeah, it's fair to say, right, that the imaging really was crucial for this case, right?
And I'll say, in fact, I was just in a social event, and a man around this age said, "Guess what my calcium score is?" And it was zero, and he was really proud of it. And he's like, "I know that probably surprises you." And I said, "That's really great news. You should still do the good lifestyle. Obviously, that's really for everybody, but of course, it's very helpful information."
That's right. I like to say some, now you have time to double down on your lifestyle. Right? You've afforded
That's right.
yourself some time. Yeah. Great. I want to go to another scenario here. This time we're going to shift to what we talked about earlier in this series, carotid, because not every time do clinicians out there have access to the calcium score of patients, depending on where you practice. You may be also using a carotid ultrasound, whether that's at the point of care or ordering it through your local vascular radiology lab. So let's talk about an older patient, let's say a 70-year-old woman in this case. She has, once again, borderline LDL cholesterol values. She also has had high blood pressure for a number of years, but it's well managed. She does not take a statin. In fact, hasn't really had a conversation about cardiovascular risk for some time. Now, let's say in this case, she says, well, I want to know more about my risk. In this case, you don't have access to the calcium score, but you do have access to a carotid ultrasound. Now, let's say she goes for a carotid ultrasound and she actually has plaque in several segments. She has plaque in three segments. Her carotid plaque score would be three. Of course, we're encouraging labs to be more quantifiable with plaque. So, indeed, she has a plaque in three segments, which is quite elevated. So, could this be valuable to her, or does the carotid ultrasound not play any role here?
Absolutely. And I'm glad you're bringing up other modalities to assess cardiovascular risk. And I always say plaque anywhere is systemic atherosclerosis. So this is very valuable information, and use whatever information you have. Sometimes these studies are done, you have this information incidentally. So that happens that you have carotid ultrasound to work up syncope, a stroke, or an MRI, or whatever it is. Use this information the same way that we use incidental coronary artery plaque. So I think for this patient, there's already evidence of plaque, and I'm really glad that in this lab it looks like the plaque was quantified, because sometimes these tests they just say no stenosis, and that's not why we're getting the test, right? We're really trying to identify plaque as the ultimate risk and to help guide management. So for this patient, it sounds like again her blood pressure is controlled, but for whatever reason, her dyslipidemia is not being appropriately managed for her level of risk. And I think there would be a strong indication for a statin. And again, visualizing the plaque, which there's the PISA study showed that showing patients the presence of carotid plaque really improves risk factor control.
Yeah, that was a really good study. You're right. I think Dr. Jory brought that up as well. That when you show patients their images, of course, in this case, carotid ultrasound, they're much more likely to adhere to their therapies. So sometimes when we give patients therapies, they walk out of the office, or maybe we didn't have time to fully discuss it. Then they leave and they say, I don't even know why he gave me or she gave me that medication. And lo and behold, 6 months later, they stop taking it. So, how does imaging in your practice, or maybe for these two patients, also play into getting buy in for long term adherence?
That's a great point, and several studies have shown this in the calcium world and the carotid ultrasound world as well. Is that seeing is believing? And this is an editorial that David Marin and I wrote about a study from Valentine Fuster that there is no question that visualizing plaque changes behavior as opposed to a risk estimate. Now, that doesn't mean you don't have to check in with the patient periodically, so that's still very important. The other thing that comes up that we didn't talk about is following up with more imaging. The other thing patients want to know, are things getting better? And I think in the carotid plaque burden, just seeing progression, I mean, that is predictive and really, really important, but it has to be quantified. A little bit of a different story with CAC, and we should not be repeating calcium scores to monitor disease progression or regression, because if we're doing everything right, the score will actually get higher. So that's something important to communicate with our patients. But knowing the risk factor control, what I tell the patients is like, we know things are better because your LDL is low and it's been low over time and your risk factors are well controlled.
That's such an important point in terms of making it real, because these questions do come up from patients. What about repeating? And I want to come back one question that you and I discussed in episode 2 as well. Let's say maybe this first patient here with the high calcium score says, well, I'd like to have a stress test. What would you say about that?
I would ask the patient, what information are you looking for in the stress test? Because obviously, oftentimes this is from anxiety, and then reassure them if you're asymptomatic, you do not need a stress test because hopefully you're doing enough activity every day that is a stress test. I'm just reassuring you that your lifestyle is a daily stress test. There is no role for additional testing. I think if everybody with a calcium scan ends up getting angiograms, stress tests, then we're not doing the right thing in an asymptomatic patient. We have a lot of data to support that. But of course, it comes up, so we have to be prepared to answer that question.
Completely. So this is a great discussion. Really take it home with these two patients that you'll see every day in your practice, or maybe it's even a family member who's asking you these questions. And in each case, imaging was the bridge between risk identification and a tailored treatment management plan. And it involved the entire interprofessional care team, right? We're going to involve our dietitians or our exercise therapists in our practice, might be a nurse or nurse practitioner, to talk to these high risk patients too, to help tailor that lifestyle. That's another part of this as well. And we talked about how the absence of plaque on imaging might change your decision. Not every patient needs the most aggressive therapy. Some patients actually have the latitude to make a personalized shared decision making that might include less intense preventive therapies. With that, we'll wrap up episode 5 with these 2 patient cases. And I'll thank Dr. Fatima Rodriguez for this great discussion. And thanks for joining this podcast about preventive cardiology, knowing your risk and acting early. And once again, Dr. Rodriguez, thank you for joining us.
Thank you, Dr. Blaha. Always a pleasure.